So with that, I'll introduce our next speaker, if we can play the slide deck. Our next speaker is Professor Saeed Hamid. Dr. Hamid is a world-renowned hepatologist, if I could say, and professor of medicine at Aga Khan University in Karachi, Pakistan. He was also the former chair of our technical advisory board for the coalition. Dr. Saeed, thank you so much for joining us, and over to you for your slide presentation.
Thank you very much, Neil, John, and Lindsay for this opportunity. And following on from the wonderful story that we've just heard, it really is inspiring, and I think it behoves all of us to do something in this area. So, Lindsay, am I sharing my presentation? Yeah. Okay.
You're welcome to.
Right. I'm just doing that. This will move. Okay.
Great. And if you want to just put it in there, perfect.
Yeah.
Thank you so much.
Okay, so my task is to talk about patient preferences and attitudes towards linkage to care and treatment for hepatitis C in pregnancy. I don't have any conflicts of interest, and Danielle's story is a perfect segue into something that I want to also present as a real life patient story. Just to illustrate the difficulties around this area and things that we need to overcome. So this is a 24-year-old pregnant female who was referred to my clinic in 2012 from the OB service as she was found to be hepatitis C antibody positive. She's a prima gravida in the 24th week of her pregnancy, feels well otherwise. Further testing shows a mildly elevated ALT. She's PCR positive. No evidence for cirrhosis on clinical lab and imaging parameters. And this is pretty much where her sort of cascade of care stopped at that point in time. She's advised the following: her liver is functioning well, and she does not seem to have advanced liver disease. Therefore, we do not expect any problems during the pregnancy. Treatment for hepatitis C is contraindicated during pregnancy and breastfeeding, as of course it is even now the only exclusion in all guidelines, and particularly the WHO treat all guidelines. It still remains an exclusion. Of course, that was also the interferon era for us, and maybe doubly difficult to treat. She was advised that she can continue with the pregnancy, no special measures were required, and she can breastfeed, which she wanted to do. But then she was also asked to return to the clinic after finishing breastfeeding and get treated promptly for the hepatitis C infection. She returns in 2022, earlier this year, 10 years after the initial consultation. When I asked her why she did not return early, she mentioned the advice of no treatment during pregnancy. She got pregnant again very soon after she finished breastfeeding for 2 years, which usually what our women do in our country, and this end of breastfeeding was quickly followed by another pregnancy. Since then, she has now had 3 children, has completed her family, and therefore has promptly returned for treatment. Now we can certainly treat her, but the only caveat is that investigations now show that she probably most likely has advanced fibrosis and cirrhosis. And therefore, even if we treat her, we cure the virus infection, she still would be at some risk of developing sequelae from her hepatitis C infection throughout her life. So what we decided to do as a prelude to trying to develop a clinical trial in these women and lactating mothers was to just do a survey of the acceptability of HCV screening and DAAs in pregnancy. And this survey was done in 3 countries: Egypt, Pakistan, and Ukraine. It was led by the group, by Jeannie Collins' group in UCL, who did most of the work in developing the questionnaire and so on. And I'm grateful to Karen Scott for allowing me to use these slides that I'm going to show you in the next few minutes. The aim was to assess the acceptability of HCV screening and DAA treatment in pregnant and postpartum women in 3 high HCV burden countries, that is Egypt, Pakistan, and Ukraine. And we present here the socio-demographic characteristics, medical history, and knowledge of hepatitis C that these women had, the acceptability of universal HCV screening at DAs in pregnancy, under the scenario, of course, that they were presumed to be, they were safe in pregnancy and had been approved for use during pregnancy. So this was a cross-sectional survey, random sampling, nothing, not a systematic sampling, nothing fancy. 630 women, 210 from each country. Ukraine was included as a potential site for women with co-infections with HIV virus. So there was one clinic that was HIV clinic that was included in Ukraine. In Pakistan, we included a major private hospital and a major public hospital with differing demographics, as I will show you in a minute. The inclusion criteria were age more than 18 years, they were pregnant or had delivered within the last 6 months, and had given informed consent for the survey questionnaires. The survey consisted of social demographics, pregnancy, and HCV history and knowledge about HCV in these women. The participants were given fact sheets about HCV and pregnancy. In Ukraine, these women read them by themselves and filled the questionnaire by themselves. In Egypt and Pakistan, they were helped in filling the questionnaire by trained field workers. Questions about acceptability of HCV screening and treatment in pregnancy and motivation for the use of DAAs in pregnancy, both for vertical transmission and also to reduce adverse pregnancy infant outcomes or for maternal HCV cure. And I'll show you the results now, which the demographics show that women in Egypt and Pakistan were younger in their age groups, a large majority under the age of 35. Some of these women had evidence of HCV infection in the past, either an antibody or a PCR test or both. In Egypt, about 3%, in Pakistan, 20%, and in Ukraine, 59%. The large majority had been negative for HCV infection, but a significant number had not been tested. For example, in Egypt, which has almost eliminated hepatitis C infection, 25% of these women had not been tested. About 10% in Pakistan had not been tested. We did not check it. Normally, women are not screened for HIV in Egypt or Pakistan, but about 40% of women that were included from Ukraine were HIV positive. Most of these women were currently pregnant. Some had given birth in the last 6 months. For some of them, this was the first pregnancy. This was a subsequent pregnancy and not the first pregnancy. There were a less level of education as expected in Egypt and Pakistan versus Ukraine. Most women had completed secondary school or college up to the college level, but not higher than that. So when asked about the awareness, have they heard of HCV infection? There was a very high level of the fact that people had heard of this infection. Egypt, 13%, Pakistan, 87%, Pakistan, 98%, Ukraine, 97%. So they have been faced with some sort of an infection within their families, HCV deaths and so on, within their families, within their neighbors, and so on. But when we asked them about HCV knowledge, there were significant gaps, questions testing knowledge of transmission, impact of HCV on health, vertical transmission rates, and possibility of treating pregnant women and children with DAs all scored less than 12 or less than 12, which was about 50% out of a maximum score of 24. When asked, do you think all women should be offered free testing for hepatitis C in pregnancy? There was obviously an overwhelming response to say that yes, women should be offered free testing for HCV in pregnancy, and they would happily get themselves tested if that was the case. When asked if shown to be safe, would you take DAAs during pregnancy? Again, a very reasonable response to say that yes, they would take the drug during pregnancy. What were the motivations? Mostly to stop vertical transmission. If this would help my child, I would take this medication no matter what. And to some extent, yes, to cure themselves as well of this infection so that they could look after their children better. The next question was, if shown to be safe, would you take DAAs during pregnancy? And this was broken down for women who were HCV positive or HCV negative. And there wasn't any great difference in the responses. All of these women would very happily take DAAs during pregnancy for almost exactly the same reasons as discussed earlier. So to conclude, we found that there is a very high acceptability of HCV screening and DAA use in pregnancy overall. Similarly, high acceptability across participant characteristics, whatever they were. And there was 60% acceptability reported among non-pregnant women with chronic hepatitis C in USA by Kushner et al. So slightly lower, but still the majority would accept DAAs during pregnancy. The main motivation for taking DAAs was prevention of adverse pregnancy outcomes rather than maternal cure. But certainly maternal cure did feature in some of these answers. The large sample size, this was a large sample size, and the first to focus on pregnant women in high HCV burden countries, and it included women from a range of socioeconomic and both HCV positive and HCV negative groups. The limitations were that the responses may have been colored by the scenario that these drugs were approved for use in pregnancy. However, the findings support the need for phase 2-3 clinical trials assessing safety of DAAs in pregnancy to provide an evidence base to inform clinical and treatment guidelines. Thank you very much for your attention.